like to request you all not to get panic. Do the 5. Practice social distancing. Follow hand hygiene. Follow respiratory hygiene. Avoid touching your face. Keep a distance of minimum 1 meter with others. Know the symptoms of COVID-19 infection. Use personal protective equipment when required. And most importantly, follow recommendations of Government of India, WHO and FOXI, and stay safe, stay healthy and stay at home.
అందరూ ఆరోగ్యంగా ఉండండి, జాగ్రత్తగా ఉండండి, మీ ఇంట్లోనే ఉండండి, కరోనాని తరిమి కొట్టండి.
स्वस्थ रहे, सुरक्षित रहे and please घर में रहे.
स्वस्थ रहे, सुरक्षित रहे और घर में रहे.
ಆರೋಗ್ಯವಾಗಿರಿ, ಸುರಕ್ಷಿತವಾಗಿರಿ, ದಯವಿಟ್ಟು ಮನೆಯಲ್ಲಿರಿ.
ஆரோக்கியமா இருங்க, பத்திரமா இருங்க, அவரவர் இல்லங்களிலேயே தனிமையா இருங்க.
নিজকি হুষ্ঠা আৰু সুৰক্ষিত কৰি ৰাখিবলৈ ঘৰত থাকো.
स्वस्थ रहो, अपने अपने घरा में बढ़ा रहो, बाहर मत निकलियो और अपनी अपनी सेहत का ध्यान रखना, सुरक्षित रहो.
Stay healthy, stay safe and just stay at home.
निरोगी रहा, सुरक्षित रहा आणि फक्त घरीच राहा.
सुरक्षित रहो, स्वस्थ रहो અને ઘરે રહો.
स्वस्थ रहो, सुरक्षित रहो और घर में ही रहो.
স্বাস্থ্যকর থাকুন, নিরাপদ থাকুন এবং কেবল ঘরেই থাকুন.
सुरक्षित रहंतु, फिट रहंतु, घरे रहंतु.
घर रबती, सुरक्षित रबती आणि फिट रहा.
सुरक्षित रहे, स्वस्थ रहे और अपने घर में रहे.
घरी रहा, सुरक्षित रहा, गर्दी टाळा, आरोग्य जपा.
The health and well-being of people have always been a priority at Bayer. In the present pandemic situation, we acknowledge and appreciate the relentless efforts of medical fraternity to deal with this health crisis. Stay safe, stay healthy.
Today, as most of us are trying to be socially responsible and staying at home, the doctors and the medical staff are playing the most crucial role of being out there in the front line in dealing with the COVID-19 situation. Bayer salutes their commitment for rising up to the occasion and going beyond the call of duty. Stay safe, stay healthy.
Okay, I think we are all set. Thank you so much, and apologies for some technical snag. I think we all need to get used to for these teething issues now. That's fine. So a very good afternoon and welcome to this webinar on endometriosis, the vision document. And let me introduce myself. I'm Deepak Chopra, representing Bayer in India. I would like to welcome each one of you, all the panelists, a very warm welcome, and to the audience as well. Thank you so much to log in for this great show, what we are going to have. Why I say so is the kind of panelists for what we have today. So along with my welcoming you all, I would like to also have a very warm thank you also, considering this special and very, very challenging situation and environment what we are into today. And being a healthcare professionals, not doctors and your teams, like, which has kept us safe at home. We all are locked up, but still we say we are fine, and we want to thank you as much. So thanks a lot from Bayer and from bottom of our hearts. So just to begin with, Bayer, like we talked, that our purpose is science for a better life. Why we say so? Because we are a life science company. And apart from our, helping and kind of supporting the human lives, we are also supporting animal health, and we are also supporting crop science. So this life science business actually partners or make us a very, very strong and sustainable partner for having development goals along with the United Nations. So this talks volumes about what we do globally, not only in this country, but across the continents and across the countries as such. We talk about our women healthcare business. We have been a global leader for women healthcare business since 1928. It's like close to 1 decade now. And the first oral contraceptive pill was innovated by Bayer in late 1960s. Hence, we talk about our heritage. We talk about our innovation. We keep on innovating, just to kind of fix our products or maybe our research in the unmet need of the humankind. Quality products, I probably will surely vouch for, and I will, I'm confident that you all will endorse the kind of products what Bayer has been launching in India or all our global assets. And specific to India, we have been awarded, nominated for, as a best workplace for women, because being a women global leaders in women healthcare business, so it kind of gives a lot of pride to each one of us. And our social responsibilities are also our corporate responsibilities, which we conduct as a social responsibility, are also women centric. So this overall gives a very strong, sustainable package for all of us. And continuing the business in terms of our contribution to the society, when I talk about business, it is not only the commerce what we talk about. It is like how do we kind of try to pitch in and improve the quality of life for women and as society, because we strongly believe if women is healthy, women is strong, our society remains strong. So, as a step to this, we have been supporting patients with credible information. We are trying to touch, women from all age groups in this country. And with advancement of technology and advancement of time, we also try to keep up with the pace of technical advancement. And with this, we launched our Bear Your Pain app in the month of January during our annual Foxy conference in Mumbai. So we had Dr. Noser, Dr. Naren Malhotra. We had a small press conference also where we launched Bear Your Pain for endometriosis. Since we are the leaders, innovators of Dynogist, Vizan, you all must be aware of, since it's available in the country. So the objective is basically to reach out to maximum number of patients who suffer from symptoms of endometriosis, so that they understand, and this becomes a gateway for each and every female who suffers from the right kind of symptoms for the disease, to reach out to the gynecologist for the treatment. So this is a facilitation what we thought we will try to do in an age where a lot of information is available across the Google platform. But yes, the right information, the credible information, and the right direction where the women is all set to approach the right doctor for her treatment. Just to take you through, the main menu would include points which are very relevant for symptoms to endometriosis patient. It's like the pain, mood, bleeding profile, and the pill consumption. So I'm not going into details, but yes, as I mentioned, the very relevant topics which are being touched. A lot of education on the disease, a lot of FAQs in terms of you can correlate and kind of get some right information as per the symptoms and as per the sufferings what the female feels about. And the second is on contraception. We understand contraception being a very, very personal and private topic in a society like ours. So this is a chatbot called Ask Tanu. Where a person can chat with the chat box and get a right direction to meet the gynecologist for whatever relevant needs they are wanting for. So as I spoke about Vizan, and we add a lot of value to our patients. And end of the day, it's like we and you, of course, in the front line, in the treating your patients. So we try to add a lot of value. So this is one program what we started, Vizan Values You. It's an adherence program because we all know that endometriosis is a chronic disease and the treatment duration is longer as it was thought earlier in earlier days. So we give third month therapy as a complementary therapy to each and every patient of yours. And in the past few months, we are proud to say that more than 1,500 patients have been already enrolled. So it's a kind of a tool for accessibility, affordability, and availability of the drug. So do support us in this endeavor. So, and of course, you have been supporting us. So we are very thankful to the medical fraternity to support this. So this meeting, let me just give you a background, we call it vision, and this document on protocol practice, we started last year when Dr. Nandita Palshetkar took over as president. So we discussed what new we should be doing, what innovative we should be doing. So there are a lot of GCPRs floating around. So we thought, okay, we'll kind of touch, very, very where a doctor actually faces day in and day out. Trivedi, Dr. Ashwath, who are as part of our elite panel today as well. So thank you so much. So we had these four modules or four parts running parallelly on diagnosis, medical management, surgical management, and fertility issues. Very elaborate, more than 230 odd gynecologists were involved, and we had 5 meetings, one centralized meeting at Mumbai where all the doctors came across the country, and 4 in each region discussing on these 4 aspects. So we had it on a couple of days back on the medical management on endometriosis. So just to inform you, more than 1,500 doctors actually logged in for this. We had a 1-hour session, and probably the session got extended to almost by 45 minutes. So I hope with the kind of esteem doctors today, the panelists today, probably it is going to be a very, very elegant and mega affair on surgical management of endometriosis as such. So you're able to see the panelists, what we had on medical management, Dr. Narendra Malhotra, Dr. Nandita. And today we have Dr. Prakash Trivedi, Dr. Ramani Devi, Dr. Atul Ganatra, Dr. Ashwath Kumar, and of course, Dr. Niranjan will be kind of moderating the whole session. So with this, I will hand it over to Dr. Niranjan, not before introducing him. He doesn't require any introduction, of course, I know that, but it is my duty. Dr. Niranjan is a professor and unit chief at Lokmanya Tilak Medical College and Sion Hospital. He is rather a national coordinator on FOXI medical disorders in pregnancy. That is the committee he heads, and I think the tenure is till 2021. So he's again the chairperson for FOXI Oncology and TT committee till he was rather from 2012 to 14. So sir, a lot of credentials to your testimonials. So I'll not go much into the detail. With this, I'm honored to hand it over to you for the session. And thank you so much from Bayer. So this is our head office based out of Thane. So thanks a lot, and would wish each one be safe and stay healthy. Thank you so much.
Thank you, Deepak Chopra from Bayer. Good afternoon, ladies and gentlemen. A good introduction of Bayer was given by Deepak, so I will not take much of a time. And today we are going to hear the surgical management of endometriosis. And we have stalwarts of endoscopy amongst us. We have already more than 1,200 doctors who have logged in and are waiting eagerly to hear them. So I would request the CVs to be displayed there. And we have Dr. Prakash Trivedi. We all know Dr. Prakash Trivedi, who is the leading endoscopist of India. And I would have to introduce him briefly. He is a pioneer of hysteroscopy and laparoscopic surgery and ART in Asia, and has a major research on fibroids, infertility, ART. The most importantly being the Health Minister's Award, which was given to him for a breakthrough where he did the in-bag morcellation and was presented at Vancouver, Canada in 2019. We all know his presidential year as Foxy in 2015. This was then preceded before by IAG in 2013 and 2015, and now presently he is the president of ISAR 2020 from and then to 2021. He is already a consultant there at Fortis Hospital, Mulund, and he has his own hospital at Ghatkopar, that is Dr. Trivedi's Total Women's Healthcare and Akar IVF Center. He is also representing India, and he did that in FIGO Endoscopy Committee and at AO for the Endoscopy Committee. He is also a well-known teacher and orator. We have heard him many times. And most importantly, 30 years back, I was his student there in Rajawadi Hospital as a houseman and registrar, and that's where I learned my guns for endoscopy. So, Dr. Prakash Trivedi, welcome for this wonderful surgical management of endometriosis to be presenting here. I would like to share you that we have got more than 1,200 audience here to see and hear from you. Please, you can start with your lecture. Before that, I would like to introduce my another presenter, Dr. Ramani Devi. We all know she was the endometriosis chair beforehand, and now presently she is the vice president of Foxy. She has got many awards which are there written. Welcome, madam, for this wonderful presentation. We are all eager to hear from you. I call upon the next slide now, Dr. Ashwath Kumar. Who doesn't know Ashwath Kumar? The brilliant South Indian vice president of Foxy, always ready, wonderful videos he shows. And the last year was rocketing with Dr. Nandita Palshetkar. He is a professor at Jubilee Mission Medical College at Thrissur and also was the quiz committee chairperson 2012-2015. He was also the vice president of KFOG in 2017. He is practicing advanced laparoscopy and endoscopic surgery and has taken training from France, Austria, and welcome Dr. Ashwath Kumar. Now I request to show the slide of Dr. Atul Ganatra. We all know he's an eminent professor and he is also an eminent endoscopist in Mulund. He is attached to Fortis Hospital. Currently he is a vice president of Foxy. He is a treasurer of IAG and the member of managing committee of MOGS. The floor is yours. Now I request Dr. Prakash Trivedi, sir, to start his presentation. Welcome, sir.
Thank you very much. It's a pleasure to be here on a warm afternoon, especially with Dr. Deepak Chopra from Bayer, then eminent people from Foxy, and a great friend and a great teacher, Dr. Niranjan Chauhan, along with Dr. Ramani Devi, then Atul Ganatra, and the dynamic Ashwath Kumar. We all are locked down, but our passion to educate, teach, and learn never dies. And this is a clear example of what we mean. Every webinar is different from any other webinar, and this is scripted and drafted by Niranjan, and it is definitely going to be of good impact. As far as surgery is concerned, I'm going to be reasonably brief for two reasons. One, that everybody gets enough time to speak, and more important is we want lots of audience interaction. Now, a few things about endometriosis is very clear. I always tell that every gynecologist feels that they are expert in endometriosis. And including myself, 90% of the laparoscopic surgeons do wrong surgery. So I think we have to understand in endometriosis when we should operate, how much we should operate, why we should operate, and most important is when not to operate. So you have to be very clear. And this comes because more than 64%, if you see 10 to 19, 18%, and 20 to 29, so more than 64% of the patients of endometriosis are below 30 years. If they don't have a good fortune to meet the best laparoscopic surgeon. So invariably, either even prior to marriage or at different ages, endometriosis has been managed by different person. Older time it was open surgery, newer times is laparoscopic surgery by a neo-endoscopist or an endoscopist who is not well versatile, or a good endoscopist, or an extraordinarily talented endometriosis surgeon. I'm going to keep my talk to common gynecologists, and I don't want to go too much into advance to dilute the importance of how endometriosis can be managed. Obviously, new medical management is coming, and it's very important. So, medical treatment with the advent of gynecologists, and especially when patient doesn't want conception, has seen a remarkable resurgence in trying to manage. I was with Professor Redwine in Calcutta and Hyderabad. I have a friend of mine, Niranjan knows, and Professor Redwine. Now, they had a great statement that if you don't know surgery, you give medical treatment. And I remember in Calcutta and later on in Hyderabad, I had to prevail and I had to tell that if you have an endometriosis in your daughter at 19 years, because surgery you'll operate. Then she goes to 24 years, now she's married. She's having endometriosis. Now you'll go and you'll operate. Then she has recurrence in 30s, then you'll operate. So bottom line is, knowing laparoscopic surgery is no criteria to touch a woman of endometriosis. You have many options available. If patient is keen for fertility, there are many products available which can be useful for fertility. So it's only when patient has severe unbearable dysmenorrhea or severe chronic pelvic pain which incapacitates a unmarried woman or a woman who is married to such an extent that medicines don't do much work, and she is really needing some relief in the form of surgery, which in today's time is largely laparoscopic surgery, because we don't want to dig a mountain and take out a mole from the pelvic cavity. Recurrent disease is another, or advanced disease is another thing. Fortunately, in India, we don't have too much of nodules of endometriosis, which is rampant in Europe and America, which may need some bowel surgeries and many other things. And when medical treatment fails, now one bigger problem with medical treatment was it is pseudo menopause and pseudo pregnancy. And I always used to laugh. What is the pseudomenopause? A patient of endometriosis comes to you and you want to delay and take her to menopausal situation or take her to pregnancy-like situation. Means the treatment is pseudo. It is not actually treating endometriosis. So you have to understand that you have to treat symptoms of endometriosis, control endometriosis. And in counseling, even when you're going to operate, the indications may vary from person to person. But I'm a firm believer as a laparoscopic surgeon, whenever you do the first surgery, it should be the best surgery. And the best person should operate. Best person operating is not necessarily the best surgeon only, but a person who knows proper counseling. So there is clear mention made in counseling about accurate relief in terms of reduction of dysmenorrhea, which may go to extent 70 to 75% you may have relief. Chronic pelvic pain, you may tell that you may largely have a relief, but some amount of pain may remain. Then reducing recurrence, improving fertility, and being in ART for a long period of time, and also being ESAR president, also reducing abortions in patients of endometriosis when they are pregnant. So after surgery, whether you will add any medical treatment or not, that I will cover in the due process of time. First, you have to remember when you label a female in India, something yellowish, something looking like tuberculosis, a diagnosis made without histopathology. It's very sad that when you make a diagnosis of tuberculosis in a female, 50% of the relatives don't talk to them. The same way, endometriosis should be not anything visible. There should be an excision and a tissue diagnosis, and preferably this itself can be therapeutic. Sonography now obviously guides us when it is endometrioma, but scattered endometriosis cannot be picked up. I made a mention that if you have a classical 5-6 centimeter endometrioma and there is a need for surgery, then this is the modern way in which we usually do. This we used to do for dermoid, wherein we used to peel off the lining. Now with vasopressin available and special needles available, you can inject in the plane between the pseudocyst, that's the endometrioma, and try and open gently. Once you try and open, obviously we all know that at some stage the chocolate material is going to come down. Please remember, I am at a different level of expertise of laparoscopic surgery in endometriosis, and I have another 15% better surgeons than me. Now we inject again, holding the capsule, the wall of the endometriosis. We have re-injected dilute vasopressin, and you can see the whole surgery becomes much more useful and beneficial. Myself, Dr. B.N. Chakravarti and IRR, we had research on the number of follicles which are removed from the wall of an endometriosis. And that was one period of time. And in today's time of COVID, we were thinking of finding a vaccine which can reduce the impact of endometriosis. So a proper surgery of endometriosis is very much important. So apart from excising, removing the cyst wall, wherein earlier Brosens and all were debating whether it should be done or not done. That is one aspect, and obviously this is moved in a bag or it is soft tissue. It can be removed from the umbilical port. Once that is done, very minimal bipolar which is used. You have to understand that whenever you operate, now this was a very good patient who came with 20 weeks bilateral endometrioma in 90s. And it was some interior of Maharashtra. So we did a principle of surgery while was like this, what we are doing now, which was making a window or a fenestrum, then using bipolar. Now the important point is she had a husband semen count of 7 million, and she was in the interiors of Maharashtra and could not come for even IUI. So that was a time when we had introduced another drug which was useful in patients of endometriosis. And if you see here the first picture, this is a recurrence. Recurrence is assured in endometriosis. So you have to be very clear. We used to tell husband can leave endometriosis, husband can leave a wife, but endometriosis will never leave a patient. So you have to understand, get your result after a proper surgery, and the best window period is immediately 6 to 7 months after surgery. So you have to be very careful when you're doing recurrent surgery. In the vast experience of endoscopic surgeries which we have, once in a decade you get a patient wherein bladder is involved. This I'm only showing because this is a surgery which has to be done by an absolute expert in endometriosis surgery. And there were times when I used to have somebody with me. Now, of course, now we are doing on a regular basis on our own. So on the left side is a bladder endometrioma. She had one child and she was secondary infertility. On the right side, left ureter had caused hydronephrosis. So you have such difficult patients, and gynecologists who got a lot of respect with vaginal surgery and our skills in obstetric got more respect by urologists when they started seeing the laparoscopic advances which we had. So we invariably call a surgeon to assist and call a urologist to stand by and watch the procedure. So on one side, if you see, we've identified the endometrioma of the bladder, and we are going in the plane in such a way so that we can excise the bladder and remove the endometrioma, which was confirmed on cystoscopy, picked up earlier on sonography. And it's a big boon that lots of gynecologists ourselves do our own sonography. On the picture which is on the right side is a uretrovesical implantation. And on the left side, if you can see how well you can enter into the plane. In previous Caesar, we used to call that as a lateral window. So you're entering a clear plane between the bladder with endometriosis. That's the endometrioma seen on cystoscopy. Simultaneously, we are having the trans illumination, which gives an idea, so that you have to excise free margin. So hold the endometrioma, have a wider margin, and gynecological laparoscopies are very good in suturing, and bladder is a very friendly structure to suture. So you excise the endometrioma. Few important tips when you're doing a bladder endometrioma: see to it that you don't want too much of redness, which you want in a fistula repair. If there is too much of redness, it will cause inflammation and it can cause collection or possibility of even an abscess. So you excise the endometrioma properly and close the bladder. On the right side, if you see the ureter which was dissected, bladder which was advanced, psoas hitch was taken, and then we have fish mouth, the ureter, and it is taken inside. I would make a special mention about two persons. One is Sailesh Puntambekar, who was very useful because I saw him doing this ureteric repair, and also our follower and an expert, even Sanjay Patel, who are wonderful in doing surgeries of endometriosis. So also Paul and many other people. So lots of people are learning, and that is an uretrovesical implantation. We had 3 such patients, but all these patients did well. None of these patients will respond to depot. None of these patients will respond to any form of treatment, whether it is older treatment or whether it is new treatment. This demands like a rectovaginal nodule and excision. Rectovaginal nodule, I will intentionally not go because it goes out of the purview of a common gynecologist. But you have to understand that if you have a patient, now you can call a fleet of ambulatory young laparoscopic surgeon who can come and help you during that surgery. Moving further, this is the biggest study which we have, the Italian Pocascio study, which has 11 years of follow-up. Equal number of patient, 44% stage 1 to 56% stage 3 and 4. After laparoscopic surgery, 49% in 1-2 conceived, 28% in 3 and 4. If you see the second last paragraph, spontaneous pregnancy rate of 23.2%. This is a word of caution for everybody who is in the field of ART, because the tubes are open and you can do a good laparoscopic excision of endometrioma of different grade when indicated. It can increase chances of spontaneous pregnancy and it decreases the abortion rate. So you have to give a good thought of doing a good laparoscopic surgery. However, a place like Brussels or many places which we have in India, where under one group we have endoscopy and we also have IVF. If you do a grade 3, grade 4 laparoscopic surgery, your pregnancy rate may be 36% in 1 and 2. After the surgery, in 1 and 2. So if you see prior to surgery, it was 49%. After the surgery, in 1 and 2 is only 36%. But in advanced endometriosis, and that is what I was listening to Dones, wherein endometrioma itself leads to significant amount of change in the ovarian tissue and also an impact on an AMH. Not necessarily, of course, today's time, even a 24-year-old patient with endometrioma, we do an AMH and EFC before doing surgery so that we are not blamed for reduction of the AMH. But here, if you see, when they resorted after surgery to a good ART, the pregnancy rate was 64.2%. So you have to remember, utilize your sonography talent, utilize your pain excellence, utilize your laparoscopy talent, utilize your colleagues in ART, whether it is somebody else's center. Don't hold the patient for a long period of time. Endometriosis, it's a big leveler. Nobody in the world has become master. And I share with you the ASHRI guideline group, which clearly told that 1 and 2, doing operative laparoscopy was better than just peeping in laparoscopy. Now, peeping laparoscopy, Atul and Ashwath and everybody is there. Nowadays, we hardly do any diagnostic laparoscopy. We are almost ready with the instrument. This is not the case with everybody. This was not the case earlier. Then Donnes and Brosens believes in keeping the capsule, whereas rest of the world feels that excision of the capsule improves spontaneous pregnancy rate, and most importantly, it reduces recurrence. Grade 3, grade 4, as I told you, if a surgery is done, it has to be done by a good expert. No matter how much you think yourself to be an expert, you can always ask to your anesthetist whether we will be in a situation to do. Even after 35,000, I do refer patients of bad endometriosis to some of my followers or some of my colleagues, the same way in which we do for radical surgery. I don't think so there can be one master of all and lack of many. Repeat endometriosis surgery, you have to be very careful because every ART person is concerned with the ovarian reserve. So repeat surgeries you will try and avoid. There are experts in Bombay, in Calcutta, in Cochin, in Thrissur, Delhi, in Gujarat, you name everywhere there are experts. See who has done the surgery, then you'll get an idea whether it is useful, whether it is worthwhile to do any repeat procedure or not. I share my ignorance on endometriosis, starting from Kamran Neza, Jack Donnes, then our own Nita Vati, and Mark Possover, Arno Vatius, Marcelo Seccaroni, Sailesh Puntambekar, plenty of other people who have been excellent and good in endometriosis. Please remember, endometriosis, the best window is after the surgery. Try and achieve the desired result, which may be pregnancy, and resort to ART whenever it is needed. Don't hold the patient for too long. I take this opportunity to thank all of you to have a patient with me. Thank you.
Thank you, sir. Wonderful presentation. You took us not only for the ovarian endometriosis, but you took us to the ureter, to the bladder, and the bowel. And we are really mesmerized by those beautiful videos. TOG webinar has seen a very high demand and viewership. Right now, I can tell you there are 1,400 members who have logged in, and it is not only India. It's not only pan-India. It's not only SAARC countries. It is not only Southeast Asian countries, but we have viewers from Europe. And yes, America is not sleeping. North America is not sleeping. And it is a wonderful presentation which we have done. The quality of the content is awesome. There are few questions, but I would like to ask you one question which has been come up here. Sir, how would you go about treating a scar endometriosis following an endoscopic surgery or a laparoscopic surgery? And this question is from Dr. Vijay Shri.
Yeah. Good that
So
she
please
asked.
be louder.
I intentionally kept endometriosis far off out of the picture because it is always a rarity. And scar endometriosis is not uncommon. Endometriosis of an episiotomy is seen. Endometriosis of lung is seen. Endometriosis of diaphragm is seen. Endometriosis of appendix is seen. Now, endometriosis of a port site is also seen. Niranjan, this is also important. It is not necessarily scar endometriosis, but it's a port from where the endometriotic tissue was removed. Obviously, you get good sonography, and in good sonography, you have soft tissue probe, which identifies the margins. And if you're getting cyclical pain and induration during period, then you're closing to the diagnosis of scar endometriosis. Scar endometriosis doesn't respond to medical treatment, no matter what you give. If you give a depot, it's just postponing your decision. Invariably, you have to excise the scar endometriosis with 1 centimeter extra margin and close it. Maybe if you feel after the surgery, you can give some medical treatment, which may be Dynogest or something. I don't give any treatment after scar endometriosis. Other endometriosis, if they are not keen to conceive, Dynogest is fine. If somebody is keen to conceive, then there are other drugs which are available. So scar endometriosis, though rare, has to be handled by gynecologist, and it can be easily done. You can have a surgeon together just to reduce the incidence of hernia, because sheath you are going to open, and sometimes a scar endometriosis is removed and you don't want. And nowadays, with buttonhole expertise, gynecs are as better as surgeons, more better than surgeons in laparoscopy, as good as a general surgeon in open surgery.
Thank you very much, sir, for a specific, wonderful answer. You have given justice to the question. Now we move on to our next presenter and the panelist. I request Dr. Ramani Devi to please come online and let's hear from you the first case discussion. Welcome. Please share your screen. Please press the green button and you have the case discussion on the slide.
Yeah.
Please share it now. Please show the slide.
Just a minute.
We are on Zoom. Kindly show the slide.
Yeah, just whatever it, or can they put it from there? It's something.
Shimon,
yes, sir. Yeah, yes, yes.
Okay, madam, you will have to stop sharing the screen. Please come out. Yeah. Then only he will be able to present. We have got now more than 300 questions being lined up, and we will be eagerly telling to our panelists. But let's hear first the first case presentation from Dr. Ramani Devi. She is going to present a very, very interesting case. I have seen the overview and it is a very interesting case. I think there will be a lot of discussion on that. We have got 3 cases which are lined up and all of us are going to go in the world of endometriosis. So let's have the first case presentation. Please go ahead.
Everybody, first of all, I thank Bayer for arranging for this excellent program along with the endometriosis committee of FOXY. Now here I would like to present a patient, a 28-year-old, married 5 years, infertile, with a regular cycle. She was in hypothyroid on supplementation, complaints of severe dysmenorrhea, and she gives history of dyspareunia. There is no history of hypertension or diabetes. Next. And with the past history, she gives that she has undergone a bilateral endometrioma surgery elsewhere 2 years ago at the age of 26. Okay. Then her next, simultaneously, she has undergone ovulation induction for 6 cycles. There are 4 cycles of IUI done, and then with none of them were successful. And so with this history, she landed with us. Now, what are you going to do for this particular patient? So on clinical examination, she was a normotensive, non-diabetic, and everything was normal except for an abdominal lap scar. And clinical examination showed a retroverted fixed uterus to the pouch of Douglas, and adnexal tenderness and vague mass was present. Okay, then the ultrasound findings are the uterus was normal size. Next, she had bilateral endometrioma, the right one being 4.5, almost 5 centimeters, and the left one was slightly smaller than that. Next, bilateral. So with this, we come to a conclusion that she is a case of recurrent chocolate cyst. Okay, bilateral recurrent chocolate cyst. Now she is keen on conception and she has pain also. Now, can anybody tell that what are the risk factors for recurrent endometriosis?
I think Ashwath or Atul can answer first.
Dr. Ashwath, are you there? Would you like to share to the world what are the risk factors for this patient of endometriosis?
Continue presentation, please.
See,
So, okay, go ahead, Ashwath.
no problem.
Ashwath, please go ahead.
She is young age. She has bilaterality, and she is a previous history of laparoscopy. Okay, 2 times history of laparoscopy. Now also she is having symptoms of dysmenorrhea, but her main problem is infertility. Okay, Here, what is the first thing what I will think about is that I will do an AMH for this patient. AMH for this patient. Okay. So the things are that I will not go for a second laparoscopy. First point. I will go do an AMH.
Ashwat, the question is the risk of recurrence.
What are the risk factors?
Risk of recurrence. These are things risk factors of recurrent endometriosis. These are the factors which are there in the patient. That is, which show she is recurrent, and risk factors means these are not the risk factors actually. What it means.
May I make a point, Ashwat, if you permit?
Yes, 100%.
Dr. Ramani Devi, there are two aspects of recurrence. One is the previous incomplete surgery.
Yes, that I made a note. Poor surgery.
And the second one is.
I think what Sir has said pertinently, it is very important. We should not say as a poor surgical technique, it is an incomplete resection.
Yeah. And then the second point is, by nature, endometriosis is supposed to recur. In fact, Nezat used to tell that 5 years or 6 years down the line, it is 75% recurrence. So there can be a good surgery done, but then she can have recurrence. So basically, if it's a poor surgery done, then the management is a little different. If it is done by a good endoscopic surgeon, then we presume that the surgery was done well. And then we have to learn how to reduce recurrence in any patient of laparoscopic treatment of endometrioma prior to handling such patients.
Atul, I would like to put this question, Atul, excuse me, I would like to put this question to you. Would you like to elaborate something on this point about the risk factors for recurrent endometriosis? Please unmute your mic. Thank you.
Thank you, Niranjan. Thank you, Bayer. I think a lot of importance should be given to preoperative counseling prior to the first surgery. When you take up the patient for surgery, and remember that the first surgery done for endometriosis is probably the best surgery, and that is why a very, very careful counseling has to be done with these patients. As a routine, what we tell our patients is that the only way we can stop or postpone recurrence of endometriosis is by getting amenorrhea. The amenorrhea could be as a result of injectable DMPA. The amenorrhea could be as a result of pregnancy, ocipil, GnRH agonists, or now Dynogest. You could get pregnant and you will have amenorrhea. In fact, there is an anecdote that I would like to share, and I said this to a patient who was in a similar situation, unmarried and 28 years, had a large bilateral endometrioma. And this is as a part of our preoperative counseling. We told her that we will operate, but remember that surgery, no matter how good the surgery is, the disease may recur. The only way the disease can stop, postpone, is by having amenorrhea. And these are the 4 ways you can have amenorrhea. And she came to us 4 months later with a pregnancy. So I asked her, when did you get married? She said, doctor, you never asked me to get married. You just said that you should get pregnant. So I think a lot has to be done preoperatively. And maybe even if a good surgery has been done, we must tell our patients that surgery alone is not the answer. It has to be followed with either an ocipil or an injectable or a Dynogest. I'm a great...
Dr. Atul, I am coming to that part of it for prevention of recurrence. Okay, go ahead with the slide projection. So failure of immediate conception and repeated IUIs are one reason for recurrent endometriosis. Okay, next slide. And failure to take post-operative management. Next. So what is the incidence of recurrence? I think they have beautifully given, even in the hands of an expert surgeon, the recurrence rate of endometriosis is going to be 20% at the end of 2 years and almost 40 to 50% at the end of 50 years. That is according to Sanvigio, where he has analyzed his patients for next 23 years. Next. So this was on 23 years follow-up. So now my question is, does ovarian stimulation, what she has undergone for IUI, increase the risk of recurrence of endometriosis? Can anybody share their experience? Because this particular patient has undergone 4 times IUI.
See, the H3 guideline is very clear that in any patient of endometriosis, when you operate it, then giving tablets or gonadotropin for ovulation induction, an IUI has 3 times higher pregnancy rate, either doing only an IUI or either doing only a stimulation. Stimulation stimulates the follicles and not necessarily it increases the risk of recurrence of endometriosis. And in endometriosis, the tubes are patent, so it's a good case. However, it's my opinion that we do prefer letrozole or N-clomiphene with an FSH injection and then do an IUI, which gives the highest result. And obviously, you will give a good progesterone support, which will be useful for supporting pregnancy and also taking care of endometriosis. We also add dydrogesterone, which can be a good immunomodulator. But it depends on the age. If she's 37 years, we will not do too many IUIs. If she is less than 28, 26 years, or as you mentioned, then doing a couple of IUI, I mean 3 IUI is at least justifiable. But do IUI with the best tablet and best injection. Don't waste the time because endometriosis will come back.
Sir, I agree with you, sir. But the recent thing has come out that stimulation for IUI causes, it poses a higher risk for recurrence of endometriosis because the ovulation that is going to come up is going to reform the endometrioma. But whereas in cases of where you have straight away taken the patient for IVF, it seems the incidence of recurrence is going to be less. That is what the recent literature evidence says. Next. So next, go ahead, continue. This is Benaglia study, and this patient had all the basic investigations done. Female factor was showing normal hormonal profile, and the most important thing is, like somebody has pointed out, the AMH level. Okay. Next, the AMH level was quite okay for her because initially, prior to the first surgery, it was somewhere around about 6. But now the AMH has come down to 3.15. But still it is on the, almost on the healthier side. Okay, next. So the male factor was investigated and the male factors were found to be normal with a good semen analysis and a DNA fragmentation index was normal. So now, what is your plan? How you are going to proceed? So you are going to vote either for surgery or for medical repeat surgery or straight away ART for this particular patient. Dr. Ashwath?
ART. Directly go for ART. I don't believe in when an infertility patient which has been previously operated comes with her main complaint is infertility. Whoever be the best surgeon, you will be losing the follicles. And so I believe in ART if it is a previous surgery has been done.
Okay, then if you are going to proceed with ART, there are bilateral masses. One is 5 centimeter, other one is around about 2.5. You want to go for any special medication prior to taking for ART? Go ahead, next slide. Are you going to take the adjuvant therapy? Okay, that's folic acid and aspirin and all those things, and the patient is definitely put on thyroid and folic acid.
Directly take the patient for ART.
Yeah.
Ramani Devi, can I make a message for so much of audience which is there? Please understand, I am the ISAR president. So we have ART for 20 years. It's not a take-home message that in young patient, once operated, only once, more than once. Once operated, you put on a tablet or depot or whatever treatment it is. Still doing IUI with a proper stimulation is better. In this patient wherein there is a recurrence of endometrioma, because recurrent surgery is proved to be of not much of use, then you have to have a specific stimulation protocol for this endometriosis. And not only do ART, preferably do ICSI, and if possible, you can even have a blastocyst transfer.
Yes, sir. So this particular patient was, next slide, please. She was put up on GnRH, Zoladex. I had given her 2 doses. Then I had called her back for the repeat scan. Right ovary has read, one particular left ovary was normal, but the right ovarian mass has increased to 5.4 into 4.5. Okay, now at this stage, this is according to the SHRE guideline. GDG recommends the use of ART in infertility associated endometriosis, especially if tubal function and male factor are compromised and if previous IUI treatments have failed. So this particular patient, after giving Zoladex 2 doses, she has got still persistence of endometriotic cyst. And plus, she says the pain is not at very much reduced. It is fairly reduced because of the GnRH analog, but still she has pain. So what is going to be your management? Next slide. Whether you're still going to go ahead with ART or you want to go for a repeat surgery.
ART.
ART. Okay, for this is a following repeat surgery. Spontaneous pregnancy after the first surgery is 41% and after the second repeat surgery is only 23%. Okay, next slide. So this then what are the indications for repeat surgery in recurrent endometriosis? Still, we cannot 100% go about with the medical management. There are certain loopholes. We need to go subject this patient for the redo surgery, telling her the compromise over the ovarian reserve. What are those such conditions?
Repeat surgery is definitely indicated, as in India, a lot of endometriosis surgery is done by surgeons. Or if the previous person who has done the surgery is not that competent according to your evaluation, yes, then doing a better surgery is like finishing the first surgery. So that's the first indication. Second, in this situation, what you have done is correct, that you've given her 2 days of preparation. The endometriomas are not going to come in the way. You can do a stimulation protocol, but you have to add something to reduce her pain.
Yes.
You also have to give a counseling to her that if you try and control pain, the endometriosis may come back. So the patient has to select between you that whether they go or ART, probably have a pregnancy which automatically treats endometriosis and the pain, which may be much better thing, and that small endometrioma doesn't come in the way of your pickup or anything.
Okay. So this particular patient was given the option of ART as well as surgical because her pain was not subsiding and she was a bit hesitant to go for ART because of the cost. So next, so this patient I had to go for, this is again a statement by ASRM says 24.4% of the patients, 18% who had undergone repeat surgery versus 1 or 2 IVF, the results are always better with 2 cycles of IVF. That is almost 70% of the patient had conceived with them. So the next one. So this particular patient, is there an option for cyst aspiration?
No role of cyst aspiration.
Only it's going to increase the incidence of
infection.
Okay. Next. So this is again a study, forest plot, where it shows that there is surgery is always inferior to the IVF and embryo transfer. Okay, next. So, but this particular patient, again, this is the question what I asked. Is there a chance of increasing the recurrence if you are going to do ART?
Recurrence of endometriosis will be there even if you don't treat.
Yes, but
whether you give
per se is not going to increase the incidence of recurrence because it is only a short-term elevation of the estrogen.
Yeah, but see, in hydrosalpinx, even when we give gonadotropin, the hydrosalpinx fluid increases when you give gonadotropin. So any pathology, whether it's endometriosis or hydrosalpinx, when you give gonadotropin, there will be exudation and some amount of inflammation which may increase. So it's better to take them for treatment and get result when our AMH is good, and you can also do embryo pooling. So you have embryo, you can transfer, then you can have frozen cycle, you can transfer, and in between you can use any other things which may alleviate her pain.
So this patient was very keen on surgery, repeat surgery, because she was a bit hesitant to go for ART initially. Okay, then I had proceeded with the repeat surgery. Next slide, please. Next slide. So right endometriotic cystectomy was done, and ultra long 1 shot of Zoladex was again given, and then again the patient was shifted for ART. Somehow I convinced her that ART will give her the best results. So I had stimulated with recombinant FSH for 10 days with the antagonist protocol. Now you tell us which protocol is ideal for ART in endometriosis. Whether you want to prefer an ultra long protocol, agonist protocol, or an antagonist protocol.
I have a clear answer, but let Atul answer.
Stop you here, Dr. Ramani Devi. We are going out of the purview of the surgical management of endometriosis.
Okay,
I'll just discuss your ART now, and we will go ahead with the surgical management. Thank you so much for your wonderful case presentation.
I'll just convey. I will condense my thing only in a few things. So this particular patient,
you have already taken 20 minutes. I have already considered your point, and we have considered that she is the case of recurrence of endometriosis. So thank you so much. We have given
Good presentation, Ramani
given
Devi.
a ART. I would proceed. We have got many questions lined up, madam. So we will get back to your case very soon. Let Dr. Atul start the case. Thank you so much.
Shriman, will you put up my case, please?
Sir, 1 second.
Dr. Ramani Devi has presented a wonderful case. It was a young lady who had to undergo twice an endometriosis surgery. She had bilateral ovarian cyst. Then she was very anxious with infertility to conceive. Second surgery which was done, there were various risk factors. She had already undergone IUI, following which she was then consulted with an ART, and that's how we have gone ahead with this case presentation. Now we are waiting for Srimon to put those slides.
Atul sir, I request you to please share the screen because we don't have your presentation.
We are getting messages. Dr. Ramani Devi, you have done a wonderful presentation, and there are a lot of questions being for you. And this was very...
Yeah, I'll do it in a minute. Give me a minute.
So I would like to thank Dr. Ramani Devi. You have a wonderful and fantastic presentation, and Dr. Prakash Trivedi, Dr. Ashwath, and Dr. Atul have contributed in your case presentation. We are very thankful to you, madam. Now we are just waiting for Srimon to load Dr. Atul Ganatra's case. In the meantime, I would request Atul, if you can start the presentation. We will load the slides. In the meantime, if you can start, I would appreciate that. Thank you so much.
I think let's go to the third case, please.
So I will share the screen.
Yeah, please go ahead.
Yes, there are going to be some technical glitches. I appreciate the seniors who have taken so much time to educate all of us sitting at home in lockdown. And it is appreciable that all three of you have come down today in our studios. Our homes are studios. So I request now Dr. Ashwath to please go ahead. Thank you.
Good evening, everybody. First of all, I thank the Bayer, as well as Foxy, as well as Niranjan, Prakash sir, Adul, Dr. Adul, Remini madam, and all the people who have given me a chance to be here with such stalwarts in the field. Okay. So something different. See, something Remini madam has something the same. This is a case of a doctor in our hospital only. 32-year-old, she was 32-year-old, came with primary infertility, 7 years with endometriosis. Okay. Now she has intractable dysmenorrhea and persistent continuous pain. But her main complaint was infertility itself. She also had failed 2 cycles of IVF. Imagine, opposite. Failed 2 cycles. She had directly gone for IVF because her initial AMH was little less. So as a doctor, she read so many articles and she thought that she will directly go for IVF. And she failed 2 cycles of IVF. As I don't have an IVF center, I do only till IUI in my hospital. So I refer my patients to my friends for IVF. Now, when she came back, I did her AMH. AMH was only 1.5 and AFC was 8. But her cysts were 5 into 2 centimeter right side and 2 into 2 centimeter on the left side. Semen analysis of her husband was perfectly normal. See, when I had so many, you can see in my mind what other things came in my mind. She did not. She was thinking. She's now asking me what to do. She has pain and she has infertility. She wants to manage both. So I thought of many things. I thought of initially giving Dinogens for 3 to 6 months and then followed by IVF. I initially thought of GnRH agonist depot for 3 months and again sending the patient to my friend for IVF. I thought of doing a laparoscopy followed by control ovarian stimulation IUI. Laparoscopy followed by directly do a laparoscopy, then send the patient for IVF. Laparoscopy followed by trial for spontaneous conception. Or send that, tell her, convince her that you go for 1 more cycle of IVF. So she was not ready for that. Then I thought which of the things, as a laparoscopic surgeon, I thought that I will go forward. So it's a very simple case actually. It's a see, usually you will see my videos of very ureterolysis and very difficult. This was done 5 years back actually. So I wanted whenever you are going with a patient with a low AMH, try to do as it's a very message to the audience what I want to give. So usually what I do is that, not like Prakash Sivai so I try to lift the ovary, and wherever the thinnest portion is there, it usually ruptures by itself. On the other side, left side, the cyst was very small, so I just drained the cyst. I did not do anything. On the right side, if you can see the left side, it is lifted so that tubo-ovarian anatomy is. So this is one important step whenever you do. Then you have to find the correct plane and do a cystectomy. See here, you know that the AMH is low. So I don't want to do too much cystectomy. See, you can see that I have up to the hilum. See, I have reached up to the hilum. So do just a small cautery at the level, not at the hilum, so down. And I don't remove, in this case, I never try to remove the whole tearing of the whole hilum or anything. So just with my bipolar at that time, just one small coagulation is done there. And coagulation is done, and just that that cyst was cut. Cyst was cut. And you can see, and it was raised, and even there were some adhesions in the rectovaginal. There is just fulgurated that part. I did not excise or anything because I didn't want to damage anything more, and the cyst wall was removed. Okay. Now, patient, then what I did was that I thought that patient, let me induce the patient with letrozole and HMG from the second day. IUI was done. Initial IUI patient was not successful. I was not planning to do more than 3 IUIs. I wanted to patient, if it is not successful, I wanted to send the patient for ART. Patient conceived in the second cycle of IUI, delivered a male baby at 36 weeks, 2.4 kg. She had IUGR, diastolic reverse, and nothing to do with endometriosis. So this was what the case is. Here, I just want to give you some surgical tips of minimizing ovarian damage for the audience. Okay, sir has, Pagasiva has clearly told, doing a minimal endometriotic surgery is more difficult than doing a severe endometriosis actually. So sir has highlighted it very well. So it's a combined, as you tell, a combined excision ablation. Use vasopressin to identify the surgical plane. So one, you can use vasopressin, and the audience should know that when will you know that you are in the correct plane? If you are not in the correct plane, you will remove. How will you know? The bleeding will be very less. That is a correct point in which then you reach the hilum. Use minimal energy sources. Usually I don't use nowadays energy sources. There are so many other things to stop. Even if you don't need to use anything, you just do cystectomy on one side, go to the other side. After doing cystectomy, and then you go back, it will be stopped. Or you can compress the ovaries, just compress it with your non-toothed. You just compress the ovary, or you can put things like snow. What I do is that you do cystectomy on side, put snow inside, go to the other side. After completing it, you just remove the snow. The bleeding would have been. Snow is something like a hemostatic agent from Johnson & Johnson, something like a cotton thing. It's not much costly, about 2,500 rupees or 2,000 rupees. Then you can have suturing if you want. I don't believe much in suturing. Avoid too much traction near the hilum. These are all small points which I want to tell the audience. See, don't think that I have done this. See, you may all think that why with an AMH of 1.5 and AFC of 8. I have enough. Then actually before doing the surgery, I went through the literature. Then role of laparoscopic treatment of endometriosis in a patient with failed IVF. This is by Cameron Nassat, where sir was standing with the photo you would have seen. Here, he had about 29 patient prior IVF failures, 22 conceived after laparoscopic treatment of endometriosis, including non-IVF pregnancy, and 7 was sent for IVF. So if that, there will be 2 criteria should be there. There will not, tube should be normal, and there should not be any male factor. So these 2 things are there. You can try like this. So this is a, see why this case has been told. These type of cases we get. We are afraid AMH is low. This AFC is that immediately we try to do, and this type of patient comes to us. Now there is another study. It's a recent fertility sterility study is there. Here also there are so many patients are there. They have studied about 78 patients there. Here also you could see that the spontaneous conception, conceived 9% of them conceived spontaneously and others conceived after sending them for an IVF treatment. So this is the message and wanted to give you is that whenever your patient has a failed IVF comes also, don't reluctant not to do surgery. Okay, if the patient has not been done surgery, they are directly gone for IVF, then they are a candidate to do surgery, and then you can send the patient for IVF. So these are the points which for the discussion point of view, I just want to tell some 5 statements. So you all can you can ask questions on it. I say that always, whenever it's an adolescent endometriosis, surgery is not the primary role. Primary is medical treatment. Then second point, which I always tell is that whenever you come with a ultrasound report, just an ultrasound report without any pain of an endometriosis, always put a differential diagnosis of hemorrhagic cyst. Second point. Third point, there is no size. Previously, they used to say that 4 centimeters should be operated, more than 3 centimeters should be operated. Now there is no criteria. The criteria is based on the symptoms of the patient. Then steps of cystectomy be told. Fifth point, which I always want, a controversial point, is that whenever a patient with endometriosis and infertility comes to you, there is no role for medical treatment. No role for medical treatment. Either it is you take the patient for ART or surgery. That may be depending on the AMH, what I told. Okay. Then thinking about the post-operative treatment. So you have done a very good surgery. What about so always you should know that recurrence is almost sure. So post-operative treatment is that minimum 6 to 12 months. There is nothing like I gave 3 months GNRH agonist and then left the patient is going to recur. So if you are planning for a post-op, and Marina is another very important thing. That is what what I do is that patient is not concerned of infertility, I put a Marina inside along with the surgery. If he has 2 children, she is not, and send the patient off, it gives me better result. And last point I want all of you to discuss. This point has been put. The last point is HRT. I always believe that HRT can be given after endometriosis. If you have done a endometriosis TAH plus BSO or TLH plus BSO has been done, even then HRT has to be supplemented. HRT can be given. HRT, especially Tibolone, can be given, and HRT can be given up to the natural menopause time. So these are few controversial points I wanted to tell. You have difference of opinion. Thank you so much, Niranjan. It's yours. Yeah. Niranjan?
Yeah.
Niranjan?
Ashwath, can you hear?
I can hear. Prakash, sir, you can make your comments.
There are a few important, in a synopsis I would like.
Yes.
3-4 very good things you did better than the previous gynecologists. Couple of things which you did was questionable, and couple of points which you suggested. First is the Nezat study which you told I have discussed with Kamran Nezat. These were 29 patients wherein ART was done in patient who never had any laparoscopy done.
Yes, yes.
So it's like the same case like yours, wherein there were 2 IVF done, which was bad on the part of the specialist at that time to consider for 2 IVF even without doing a simple laparoscopy. So that is point number 1. Second is in laparoscopic surgery with 1.5 AMH, you started off very well. Everything was fine, but nobody will agree that we should excise the cyst wall. That's a point which is important. Then you were very lucky that in 2 cycles of IUI, you got conception. And this is what I keep telling many of my ART consultants, because at one period of time, 25 to 30 ART consultants scopy I was doing. And there were so many spontaneous pregnancy rate that I used to be scared to talk to the ART person, because if we do a surgery and patient is conceived, and I was so happy that every ART person told me, no, we are very happy no matter how the patient conceives. So what you have highlighted is certain important points. And second, the key message what is for audience is, by chance if you have operated, then see to it that the patient conceives in first 6 months, because that is the best immunological window when you can get highest pregnancy rate, wherein as you also use letrozole, I use letrozole or enclomiphene, and I add FSH or HMG. Usually I add FSH. And there are many different things which will, when we'll answer Ramani Devi's question of how we can stimulate. But overall, your synopsis, it's a good case presentation. You worked good like an endoscopist, and you didn't get sold to the ART bug. So I think so you're sticking to the theme of surgical management of endometriosis. So it was a good presentation. Niranjan. Atul.
Dr. Niranjan.
Atul.
Yeah, can you put my question, Shimon, please? Yeah, can we go on? Yeah, so now, friends, we have another clinical situation here. And I think here in this situation is where I think it will test our patience as to how counseling needs to be done here. We have a 28-year-old unmarried woman with complaints of left abdominal pain, chronic pelvic and lower back pains in 6 months. The pain has progressively increased during this time. The pain is especially severe around the time of her periods to the extent that she cannot concentrate on her work and daily activities. She is extremely ambitious and hardworking, has not planned pregnancy or childbearing as of now. On ultrasound, 2 intramural fibroids measuring 7.6 into 6.7 into 80 millimeters. On the posterior wall, pushing the endometrial cavity anteriorly, a small fundal anterior wall fibroid, which is around 26 millimeters. The right ovary shows a well-defined cystic area with internal echoes measuring around approximately 7.5 centimeters. There is no evidence of any solid component or likely a hemorrhagic cyst. To take this further, an MRI revealed that she had a 6.8 into 7.2 centimeters mass, of course, which is a posterior wall fibroid. At laparoscopy, her findings were large right endometriotic cyst 12 into 10 centimeters obscuring the uterus. Surgery details, the only thing that we have is that the patient underwent the right ovarian endometriotic cystectomy and a myomectomy with adhesiolysis. I think before we discuss the treatment options, I would like to ask our senior most person here, Dr. Prakash Trivedi, before you take this patient up for surgery, how will you counsel this patient? She's got, her main point is pain. She doesn't want pregnancy. She's not wanting to get married.
I think so. From laparoscopy point of view, she looks copybook. Whenever anything is copybook, don't take it for granted. So you have to discuss with at length the importance limitations, and problems related to surgery. So you have to counsel that you may be relieved of fibroids, you may be relieved of endometriosis, you may be relieved significantly about your symptoms. But since she is unmarried, you will also put a word of caution. The best method will be laparoscopy. But her AMH, you told me, or I didn't read?
So we were not given the AMH. So again, a part of counseling. Would you like to do her AMH?
Yeah. So any patient, whatever the age it is, even 20-year-old patient, 21-year-old patient, AMH and AFC is preferably, AFC is difficult with abdominal sonography. So AMH has to be there.
So sir, I'll just add to my question. Say we have 2 situations. We have a 28-year-old girl. 1, the AMH is normal, and 2, the AMH is low. So how will you counsel these 2 situations separately?
Yeah, so the second question is easier to answer. If the AMH is low, first we'll have to tell that she should get married. I would not tell like you get pregnant.
Yeah, I made a mistake, sir. Counseling, that's why counseling.
So, so that is one point. If the AMH is reasonable, she is an ideal patient who is suited for laparoscopic surgery, and you will tell the advantages of doing a laparoscopic myomectomy and endometrial cystectomy, also mentioning that myomas may recur in 5 to 10%, and endometriosis will recur much more. So after that,
let me stop you here. 1 minute, sir. Now, you said that if she says she's willing to get married, will you wait for surgery till she gets married because she's got pain?
No, if she's planning to get married, I'll be happy to do the surgery prior to marriage so that immediately after marriage, the couple doesn't have to bother about surgery.
Okay, because she will have to tell the family that she had a surgery done. So,
yeah. So suppose if she is likely to get married, she can have the prospective spouse. Very often we have, so we can give an option that you can wait. But better thing is, if she's at mother's place, finish the surgery, show the video to the prospective husband and tell her fertility will not be affected, presuming that the tubes are all right. And if the AMH is like say 3.5 or something, then laparoscopic surgery. And most important part in counseling, you tell that laparoscopic surgery is not the end of the story. You have to follow medical treatment for at least 6 to 12 months, if not more, because whatever the treatment, you may give Dynogest, you may give progesterone. Of course, depot is out of question because depot is, Danazol is paracetamol for headache. So forget about Danazol. I don't think so we waste time on Danazol. Depot is one thing which is only given when you want to build the hemoglobin. Depot is just going to suppress. So in realistic terms, she's not keen for conception. Then adding Dynogest, which has studies up to 5 years, can be considered. And
your first choice, sir, between giving a GnRH agonist initially, or you would put her on Dynogest straight away?
No, only Dynogest. After the surgery, only Dynogest. And patient keen for fertility is a different issue. So that is depot. What happens is it just suppresses. Suppose if you feel that your surgery is probably not totally complete, then let us be practical. Every surgeon does a fantastic surgery on one day, and some surgery is not that great. So if you have little doubts that your surgery is not very complete, then you will give one single depot and then on Dynogest, but not as a rule if you have done a good surgery.
Sir, we'll come back to you. Ashwath, you have only 4 sentences. Ashwath, 1 minute. Ashwath, 4 sentences in how you will operate. 2 for myoma, 2 for endometriosis.
Okay. So in this case, anyway, you are told that you are going for operation. For myoma, anyway, for both vasopressin. First sentence. Vasopressin has to be injected. See here, where you need to inject, no need to inject separately. In this case, if you inject in the uterus itself, some effect will be there in the ovary and additional lysis.
That's your next step.
Second point on myoma is that try to do anyway. You cannot point in this case is that you cannot have a second surgery. Very difficult in this case actually. So your first surgery should be complete. Try to do the complete myomectomy with proper closure because we are planning for fertility. Coming to endometriotic cyst, see it is here also the same thing. Proper cystectomy should be done. Patient is having pain and such a big cyst. And one more thing is that nowadays excision of the cyst wall is not needed. Full cyst excision is needed. Don't excise the ovary.
Okay.
So previously,
1 minute. Ashwath, low AMH, will you do cyst wall removal?
No. Low AMH means I will do minimal. You have to, because the patient is having, otherwise it will recur. Patient is not planning to get married now. So you have to do a cystectomy. Otherwise, no use of doing. So cystectomy in a controlled fashion, whatever I have told. I have told you heard whatever I have told.
Okay. One more point. What suture material will you use for the myomectomy?
Myomectomy V-lock. That's the barb sutures we use, and barb in 3 layers, whatever layers. Nowadays I use for myomectomy every time barb only, and inverted. You put a baseball.
We'll come back to you. Dr. Prakash Trivedi, will you suggest egg freezing in this patient?
Sir, unmute the mic. Unmute the mic.
Is normal.
I think
I'll come back to you, Ramni Devi. I'm coming to you.
AMH is normal, you told, or what you told the AMH?
Both the situations. She's not wanting to get married. She doesn't want to have children. Are you going to talk about egg freezing to her?
Yes.
See, we are deep into ART for almost 20 years. You have to remember that egg freezing in a genuine patient is a different issue. But egg freezing gives miraculous result. Please don't listen to the ART practitioners. I am very clear about it. Suppose if you are a film star, you are now 30, you want to preserve your eggs, you're going to get married. This patient per se, presuming that she is 28, 30 or whatever it is, there is nothing that you have to push her for egg freezing. You can have standardized treatment protocol and you can go ahead. What I'm trying to tell is egg freezing is too different from embryo freezing. The results of egg freezing in India is not phenomenally high. It is not bad at all. But I would not like to put every patient, because you'll have to do TVS pickup, you have to do many other things.
Thank you, sir. That's what we wanted to hear. We'll come back to you. Dr. Ramani Devi, post-operative medical management.
Post-operatively, if the patient is not going to go get married immediately, I think we have to put her on Dynages. I very well agree with Dr. Prakash, because GnRH, what you are going to give is going to have severe hypogonadotrophic effect. She might suffer from hot flashes and menopausal symptoms. So ideal will be Dynages. And there is another study by Dr. Thomas where he had followed up his patients for a period of 5 years. He says that always Dynages has got a better thing, and patient's compliance is good with that when compared to GnRH.
Okay, Dr. Ramani Devi, you have put the patient on Dynogest. After 3 months, she has spotting, continuous spotting for 10 days. How will you manage?
Yeah, this is one thing is there is patchy atrophy of the endometrium that is occurring because of Dynages. So initially we can counsel the patient that it might settle down with few or one or few 2 cycles. One is you can otherwise stop it abruptly, then restart it, or you can give a GnRH, one shot of GnRH, which can suppress.
Okay, and this counseling of breakthrough bleeding, will you do it prior to starting Dynogest? Or
Yeah, we need to talk to the patient prior to starting, or sometimes I would rather prefer, currently I give my patients, all my patients, one shot of GnRH, which will suppress, then I start the patient on Dynages. By that, they are very comfortable. They don't have much of breakthrough bleeding.
Any role of giving DNRH BD twice a day? Do you step up GnRH?
No, Dynages, I mean.
Yeah, that's right. Sorry,
yeah, you can go up to 4 milligram. There are studies which say that we can top up the dose for twice a day, and then you can taper it off.
We had an expert who had come some time back who said use vaginal norethisterone or oral norethisterone. Any experience on using vaginal norethisterone?
No, sir. I
Absolutely. Don't. Okay, Dr. Prakash Trivedi, your call on, you have a patient on Dynogest who has spotting in between. How will you counsel and manage?
More or less like Dr. Ramani Devi told, because Dynogest, unlike the other medicine, we tend to give in a continuous fashion. So basically, you will be telling that if you get amenorrhea, it is fine. And this is a big issue when patients go abroad. They go with 6 months tablet, 9 months tablet, and they are abroad and they don't know what tablet to take or what we should. So you have to practically tell that you may have occasional spotting for which you may take symptomatic treatment and don't get scared about it. But you have to counsel about that. It is not that high as it used to be in DMPA depot and all. So it's not that much high, but you have to obviously counsel. But it's a good drug.
Come back to you. Ashwath, I have a young girl who's about 25, 26 years of age. She just has bilateral 3 centimeters endometriotic cysts. Severe pain is the complaint. She was going steady with a guy, and the guy has refused to marry her because of the endometriosis. And she says, will you talk to my better half about endometriosis and that I don't want to undergo surgery. She's very happy with Dynogest. How will you counsel the in-law family?
She has got married?
No, she has not got married.
Okay. So the would-be in-law family, you have to tell that endometriosis is not a disease that she will not get pregnant or anything. If you have a specific treatment for endometriosis, that pregnancy is not an issue, she can become pregnant. The second thing is that once she gets married and she can try for pregnancy, and if she is becoming pregnant, that itself gives some relief for the disease. Then even if you go for a surgery, if the pain is intractable after Dynogest, if she is happy with Dynogest, she can continue for even 5 years. If she is not relieved by all these things, she can go for a surgery also without much problem. So give all positive things to them to the in-laws, but to the patient, I always tell that there is high chance for recurrence and chance for decrease in AMH, and all these things would be told to the patient with positive to the in-laws.
Dr. Ramani Devi, there were some side effects described like recurrent vaginal infection, sore throat, upper respiratory infection, running nose, gaseous distension of abdomen with Dynogest. Have you experienced any of these things?
No, sir, I don't think. Except for most of my patients, they complain of breakthrough bleeding, spotting, and some bloatedness that is secondary to any progestational effect.
It's called meteorism. That's what I was talking about. Bloatedness is meteorism, excessive gaseous distension. So how do you manage these situations?
I haven't had such situation.
Fair enough. I think
maybe we can suppose if they are not if progesterone is going to be the culprit, then we need to switch over to some other drug.
Dr. Prakash Trivedi, very often a patient comes after about 3 or 4 months and tells you, okay, this particular brand of Dynogest that you're giving me is more expensive. There are others which are cheaper. How do you counsel these patients?
Yeah, two things before I answer that question. First is, Atul, it's very sad and paradoxical. When a woman has some pathology, they always disclose to the would-be spouse. Is there any single female who gets married and asks husband, what is your sperm count?
Maybe that should be the norm. Show me your sperm count and I'll get married to you.
No, sperm count or mumps. What I'm trying to tell is it is a little bit of bias. So basically in counseling, you have to tell incidentally she has a small problem. For example, you have something we don't know. That is one. Coming to your question, what is the question you told?
No. If a patient after about 6 months of Dynogest comes and says that I've
Now see, let's be very clear. Every company produces a product, and it is impossible. Even if you see, somebody told at the fag end of the day. So even if you see cigarettes, there are 100 types of cigarettes which are made. Now nobody can tell A brand and B brand is the same. Visan is having high level in terms of popularity and patient acceptance. That doesn't mean that other brands of Dynogest is substandard. One biggest take-home message is don't just write Dynogest, because Dynogest itself is also a brand. So by default, you get benefit to whichever company, which company it belongs, it doesn't know. When it comes to costing, that is my personal opinion. When we do laparoscopic surgery, IVF, we always tell we have believed the best surgeon, best person, best treatment, irrespective of the cost. So suppose if you are storing the tablets, then you can give at the cost which is available to you. It becomes cheaper than any cost which they can get any other medicine. But there are people, not necessarily in this brand, but if we go into the dydrogesterone group, there are again two products wherein one is costing more, one is costing less. So there are a lot of issues which can come into picture.
I think I just tell them good things come at a price. Niranjan, over to you. Thank you so much.
Thank you, Dr. Atul Ganatra. We are very happy to hear that the viewers have really appreciated your efforts to discuss this case, and the questions were scientifically answered by the masters of endoscopy. And now we are lining up with a question and answer session. And I go back to Dr. Ramani Devi. Yes, madam, there is our viewer who is very excited and is very curious about the case which you presented, whether she conceived or not. So would you please answer? The mic is yours.
Yes, sir. So this particular patient, I did an ART following repeat surgery. I could retrieve 11 eggs, and then I had 8 embryos, and 3 initially I transferred, and she had a singleton baby. And then subsequently, to my surprise, she has conceived on her own. Probably that is the effect of surgery, I feel, because the anatomy is not altered. But one thing I would put in a message to all the viewers is that when a woman conceives following treatment of endometriosis, you view it at a high risk, because she is at a high risk of developing miscarriages. Ectopic pregnancies are very high, and subsequently there are problems with the fetal development. She can have an increased incidence of antepartum hemorrhage. Placenta previa is more common. Intrauterine growth restriction is more common, and the incidence of pregnancy-induced hypertension is also there. Then one more thing is, if she can present with problem of acute abdomen during pregnancy, we have to think about certain factors. One is bowel perforation, especially in patients who have undergone endometrioma, because there is thinning out of the decidualized bowel during pregnancy. Other one is spontaneous intraperitoneal hemorrhage can happen in this, that though it is rare, but we have to think in our mind. So I think pregnancy following endometriosis is not without a risk. And I saw one question flashing, why there is increased incidence of recurrence of endometriosis following IUI? Because that I said, in IUI, when you do the ovulation, there is spontaneous ovulation, and spontaneous ovulations are a cause for endometrioma formation. But whereas in IVF, we aspirate and there is no option of all these things, spontaneous ovulation occurring, that may be one reason, and a very short time and a single episode of IVF may not cause that much of recurrence.
Thank you, Dr. Ramani Devi. We go ahead with the next question to Dr. Prakash Trivedi, sir.
Yeah.
There is a patient of recurrent scar endometriosis at the episiotomy site, and we have excised it twice. And she has not responded to Dynogest, DMPA or OCP. Dr. Akshita Panwar would like to know from you, how would we go about in this case now?
Yeah. This is something important which I once discussed with Dr. VP Paili, similar case which we had. And basically here what you have to understand, that there is often a sinus formation. Even when you have an endometriosis of the episiotomy scar, in addition to that, there is a fibrotic sinus formation. So you have to take care when you're doing the surgery. You excise the endometriosis, you go till, with a methylene blue, you go till the base wherein the sinus ends, and very classically a surgeon assists me to excise the sinus much more meticulously, and that is how it can be taken care of. One important thing Dr. Ramani Devi just pointed out, I may finish her point. IUI gives 12% success and IVF gives 36 to 40% success. That is why if you have IVF pregnancy, then endometriosis will be less. That's point number one. Niranjan, one last point I would like to tell about stimulation. How do you give a stimulation in a patient of endometriosis? Niranjan, it's fine if I make a comment?
Yes, sir.
Yeah. Now, you have to remember, if the patient is less than 35 years, young, and with good AMH, they carry good chances of ART, and the ideal protocol is to give a depot injection on second day of the previous period. Day 25, start estrogen, ethinyl estradiol twice a day from day 25th day, and continue. Give gonadotropin stimulation so that you have synchronized follicle, and give recombinant HCG. Now, if she is having less AMH, she is not a poor responder, and this is a patient wherein you will not downregulate with the depot. You will give estrogen priming, and after estrogen priming from day 25, you will put her straight away on gonadotropin, a little higher dose, and then consider. And the last thing is, if she's close to ovarian poor response, then you will start testosterone gel on the previous cycle twice a day, which is applied till you start the stimulation. Then you give stimulation, and if your lining is less, then on day 7 of stimulation, after that you can give growth hormone, and there are many other things. So I think that may make that her answer complete.
Thank you. Dr. Prakash Trivedi, we move on to Dr. Ashwath.
Yes. Yes.
There are various questions, but you can see one question which is there in front of you. Dr. Sangamitra Das, she has sent to us
yes.
a minimum cyst size which we can induce ovulation without going for a surgery. Next part is, in fertile patients, sometimes the chocolate cyst is on the ultrasound finding and the pain is minimal or it's mild. So how do you plan in this case for any surgery?
What was the first case? First case, Niranjan, first case?
Yeah, this is just above you. If you see the chat, minimum cyst size is
okay, but there is no minimum cyst size. Actually, the size of the cyst now doesn't matter at all for surgery or ovulation induction. That is the first thing. For the second question, she has asked, what was the second question?
is basically what would you do? You would like to go for a surgery. So assuming if it is more than 5 centimeter or less than 5 centimeter, what is the cutoff point, or is it less?
No, there is no cutoff point for surgery as well as ovulation reduction. Both no cutoff point now. Previously, it was like size of the cyst and all. Now, but for there are bilaterality and unilaterality. There is something. If you have an unilateral only cyst, you can go for a surgery. While when it's a bilateral and an infertile patient, you have to be very careful because the chance of decreasing fertility is very important. So there is no size of cyst is there, but there is unilaterality and bilaterality gives some matter.
Okay.
Another question I saw was snow. They had asked about, I had told snow. They have asked about snow. Snow is obtained as snow itself.
Yes. Dr. Chellappa has asked.
Snow itself.
Sorry.
Snow is snow only. Trade name is snow from Johnson & Johnson.
Okay. Dr. Atul, there are many questions for you also because the way you have explained and gone ahead with the surgeries to be performed. But what would you recommend? Is ulipristal also to be given with Dynogest for a case with fibroid and endometriosis? Or only you would like to go ahead and do a surgery for fibroid, and if she is not interested in fertility, then would you like to add ulipristal along with Dynogest? Would you please
unmute the mic.
Unmute your mic. I request all of you to unmute your mic.
As of 20th of March 2020, I repeat, as of 20th of March 2020, the European Society has banned the use of ulipristal because of extensive liver injury. The article, you can go on the net and look at the article. 20th of March 2020, ulipristal has been suspended as a drug because of extensive liver injury till further orders. So I think we won't have that discussion at all.
So I think the answer has already been given by you, Dr. Raja. Ilavarasi, you have to understand that we cannot combine both. Please go ahead and treat her endometriosis, and we will go ahead with the further questions which are there. How can failed IUI become a risk factor for endometriosis? Dr. Rita Darbari is asking. Dr. Ramani Devi, would you like to answer this?
I had already explained this is only, it's failed IUI is not a cause for recurrent endometriosis, but stimulating, ovarian stimulating, repeated ovarian stimulation, that becomes a risk factor.
Okay. There are many. I would have to select only one or two because we have got constraints of time. So, Dr. Prakash Trivedi, you are the legend of endoscopist in our country. And in this, if you have a patient who has got endometriosis along with tuberculosis, post laparoscopy, once you go ahead and do the surgery, how will be your line of action in a case of infertility?
I think so. There is a very interesting question, and I will just geographically answer. Why geographically answer is we have coastal regions, which is Goa, Mumbai, Cochin, Chennai, Calcutta, and so many other places wherein the incidence of endometriosis is high. If you go in the center of India, for example, Bihar and UP, patients marry early and have many children, and there is little higher incidence of tuberculosis and PID. Tuberculosis and endometriosis, PID and endometriosis cannot coexist because once you have excessive phagocytosis because of inflammation and infection, endometriosis will not survive. Endometriosis remains in patients who have advanced age, has not been affected by PID. So only a patient of endometriosis with an open tube now gets married and has some source which may be through the sexual contact or maybe hematogenous, and she develops tuberculosis. That's only a rare case wherein there can be a combination of the two. Invariably, most of the tuberculosis we have is the effect of tuberculosis seen on laparoscopy along with endometriosis. So you have to see which is active. So if the tuberculosis RNA-PCR is active, you have to treat that. If there is only effect of tuberculosis which is seen like beaded appearance, etc., there is no active tuberculosis, check for hysteroscopy, see the endometrial lining. treat the endometriosis, check her AMH, and she will be an ideal case for taking up for good ART with little higher dose of stimulation depending on AMH.
Dr.
In
Ashwath,
India-
there is a last question now. Dr. Ashwath, due to time constraints, I request you, there's a last question for you. Thank you, Dr. Prakash Trivedi, for wonderfully explaining that both do not coexist together. And we would like to end here with the last question, which is asked to Dr. Ashwath. Dr. Atul Ganatra, you were also amazing. Now this question goes from Dr. Anshika. Do you do chromoperturbation after cystectomy? Dr.
Definitely,
Ashwath,
definitely, because infertility patient, you have to do chromoperturbation. And one last comment for Prasavay sir told, tuberculosis is a differential diagnosis for endometriosis. So whenever you have a cyst, malignancy, tuberculosis, two things at the end of your mind should be there. The only thing that, okay, you have an endometriosis going and you are all, as youngsters, we all do now what you don't know, endometriosis surgery to the extent which we are all doing. The sir will not be agreeing with us, definitely. So we have landed in trouble actually. One or two times I have landed in trouble. So I know that once I had to manage a case of malignancy. The report CT MRI was endometriosis. I went inside, it's hard cyst. Went inside, started doing, and finally the report came as epithelial ovarian malignancy. So after that, I am very careful. And tuberculosis, another diagnosis. Tuberculosis, it is another case which we should be very careful when you are going to operate, because medical treatment is there. Most of the time, it is a medical treatment. So do things at the end of the last. It is not endometriosis. At the end of the mind to end. Two things in your mind, tuberculosis and malignancy at the site.
And reverse can also happen, Shwet.
Yeah.
See, a patient with a patient complaining of very high CA125 with adnexial masses, it still can be endometriosis.
Endometriosis. Malignancy will be patient coming with malignancy.
That has caused a very
correct,
high
madam.
CA125. So
diagnosis comes as with malignancy, and when we operate, it will be endometriosis. That is also. So all these things are quite
increased because of peritoneal irritation.
Yes.
May be endometriosis, may be tuberculosis, may be pregnancy.
Yes.
Anything. I think so. Before anybody ends, I think so. We have to give a big round of applause to Niranjan Chavan for organizing such a fantastic webinar with almost 1,390 people chipping in. And also, I would be thankful to Deepak Chopra and the other, all four of us, myself, Ashwath, Atul, Ramani Devi, all of us feel very indebted, and we feel humbled to share our experience and pleasure that you were interacting. Thank you very much.
Thank you, sir.
Thank you.
Thank you, all of you. Nandari, Vanakkam, Dhanyavad. Thank you to the wonderful panelists and our audience, Dr. Ashwath, Dr. Atul, Ramani Madam, you are awesome. Of course, Dr. Prakash Trivedi, आपकी क्या बात, आपके बारे में क्या कहना. And
finally, stay back, stay at home, stay safe. Thank you.
Yes, madam, we agree. Dr. Atul, so nice. I know you're busy consulting, but still you have given us time. Ashwath, you have been beautifully explaining, all of you. And before we close, I would love to tell our august audience that we have received requests from speakers globally. Today we touched, sir, I would like to correct here, we have totally 1,480 audience from global, because Bayer Endometriosis Vision Protocol is a global protocol, and Indians have been seeing, not only Indians, but people from all over the world are seeing us, and it is an awesome experience which we are going through, all of us. I would like to share, I would request Raymond to please share the slide. We have one international speaker, Dr. Lee Kin Wai. He is a senior obstetrician and gynec from Singapore. He has also joined, and he has seen, and he has agreed to be with us on 22nd of April. He will be live. His topic will be minimal invasive to non-invasive virtual surgery for fibroids and adenomyosis. And he has accepted the invitation. We all will be logging in for the TOG webinar. Till we meet again tomorrow, घर ही रहा, स्वस्थ रहा, अपने फैमिली और अपने दोस्तों से दूर रहिए, लेकिन आप साथ रहिए, and keep seeing TOG webinars. Thank you so much.
Thank you.
Thank you.
Thank you.